So we're actually going to run directly into the last session, which is going to be an open discussion. I want to first invite up to the stage Dr. Umar from the National Cancer Institute, Dr. Morgan from the University of Alabama, Birmingham, and Dr. Park from the IARC. And I would like to remind everybody that we have a very, very nice wine and cheese reception right after this discussion. So apologize for taking away the break, but we will pay you back later. So since I think everybody except Dr. Umar has been introduced before, so let me go ahead and take this opportunity to introduce Dr. Umar. Dr. Umar received his PhD in biochemistry and immunology at the Johns Hopkins University. He conducted his postdoctoral training also at Hopkins and at the National Institutes of Health. Then Dr. Umar is now a program director at the National Cancer Institute. His research contributions include deciphering the biochemical defects in Lynch syndrome and publishing testing guidelines for Lynch. As a program director, he oversees a wide variety of grants and contracts focusing on cancer prevention, translational research, screening, and clinical trials. Some of the major research areas and grants that he has funded include novel mechanisms of NSAID in cancer prevention, cancer stem cells' role in cancer prevention, green tea for cancer prevention, the role of DFMO, which we heard about in a previous summit, in cancer prevention, national polyp screening trial, and a host of other funding trials in his portfolio. So Dr. Umar has made a large impact on the science of cancer prevention in the United States. And so how I think we are going to run this panel is this is going to be very open-ended. I think I'll, if anybody...
In fact, you guys better pay attention because I already know that this is going to be a two-way conversation. So the panelists have been given the go-ahead to actually ask specific members of the audience questions as well.
There we go.
Because Doug already came up to me. He's like, "This is what I'm going to do." So heads up.
Right. So it's going to be a little bit pimping style here.
They might not allow us to do that to the medical students anymore, but.
Okay, so anybody? So maybe I wanted to start with something, and I'm going to ask this.
It's your prerogative
of Dr. Umar. So I think this question is probably on a lot of our minds, and it relates to a recent event which occurred on Tuesday this week. So we're going to have a new administration.
I don't know what you're talking about.
We're going to have a new administration coming in, and there's going to be likely unified Republican control of the government. So how might this impact scientific funding over the next 4 years? And if it does impact scientific funding, what can be done to mitigate its presumed negative impact on gastric cancer research?
Thank you, Rob, and I really want to thank you and Juha and Lai, people who organized this, invite us here. It's been a wonderful meeting. Yes, so in response to your question, the short answer is no one knows, but a little bit more nuanced answer is that, there are changes in administration every 4 years. I think cancer affects everyone. Cancer does not discriminate if you are a Republican, Democrat, conservative, or liberal, or in between. So I think that is the key, that there is a support from both sides of the aisle. Overall, if there are changes in the priorities for the administration for overall budget, that's a different question. No one really knows, and we'll probably look at in the news whatever happens along those lines. But I think pretty optimistic about. In the past also, that's how, in terms of research funding, it has pretty much stayed similar. There might be bumps in the road, but I don't suspect there will be like huge earthquakes and stuff like that, and no need to worry about that. I think we need to just really keep on moving our research, our priorities. What we can do is to move that forward. I think there's like wonderful ideas at this meeting. A lot of progress made I've been coming from the beginning for this meeting. Many of those ideas were just like thoughts, and we really have implemented like guidelines and even like increase in funding from some projects. So encourage those researchers in the audience to really submit a lot of proposals, a lot of good ideas. There's different mechanisms. Anytime, contact me for anything for gastric cancer. That's under my purview for prevention, for early detection. Anything that you are interested in, we can talk about it, how to really move forward and help along those lines.
Go ahead, Doug.
Well, and a follow-up question, and really not a fair question, but certainly of interest to everybody in the room. Would you say that in the NCI portfolio, the gastric cancer is appropriately funded or underfunded, especially when we bring in
That's a trick question, by the way.
Sure. Yeah.
when you bring in the level and significance of the cancer disparity?
Yeah, no, absolutely fair question. And so NCI does not, it's not like DOD funding, as we heard from Hajin. That's not like the specific cancers or organs that are targeted. It really depends on the investigator-initiated proposals. So you really have to submit those proposals, have to be good proposals that really get funding. But to your answer, it's not a fair representation by all means. Gastric cancer portfolio funding is really very low. Maybe one of the lowest. I don't know if anyone has looked at, but there are many cancers that are underfunded, esophageal also, but I think gastric is even lower than esophageal cancer. Esophageal adenocarcinoma, that's pretty close to similar numbers, but I think maybe there are some funding opportunities that were there for that. Gastric didn't get that advantage. Liver is also low, not very high on those. So there's a lot of work that need to be done, and I think that's part of the things that I heard is also the resources, having these biospecimens repositories, and that's been like discussed. So I think to put proposals together, you guys need those to really get that a good proposal to submit that. So we're kind of like.
Yeah, I think, in part it's our fault because we're not submitting competitive applications. But I think it's just because we've been behind, right? I didn't start out my career in gastric cancer, and the teaching was it's not a problem here in the U.S. But as I practice clinically and see more and more patients, and we come up with new techniques to effectively treat gastric cancer, I think that it's now we've become aware of it, and so I think that there's increasing momentum. So. I do think that, we'll be submitting many more high-quality applications. I guess the way to twist this, though, and follow up with Doug's comment, is that in general, there are no RFAs that are specific to gastric cancer, though, right? Mm-hmm. It's such an underfunded cancer. One thing that would really help the field would have a gastric cancer specific RFA, because I think there are clear reasons to support that. And if we had an RFA that was specific to gastric cancer, one, I think you would see very high quality applications for that. But two, it would assure us that, we're specifically addressing this particular clinical unmet and underfunded entity. Right. So I guess what's the process of getting an RFA, and are there any ways to get an RFA specifically for gastric cancer? Yeah, so I think what I can imagine, there's a possibility of doing something more like along the lines of what we did for esophageal adenocarcinoma, to have like a translational research network. The idea there is I think it was very similar. The reason I'm mentioning that is a similar situation where
the resources are, I mean, people are doing research, but everyone had like small set of samples.
So that's like the BetterNet.
Yeah, BetterNet.
Yeah.
So I think that was an RFA, for example. So that will be one model
Right.
to put together. And I mean, for process for that is internally from NCI. And recently we've been talking about, as Costanza talked about, we did that think tank and we discussed with NCI director possibility of doing something along those lines. What form that would be, I mean, something that, again, it really depends on what the budget is, but all that set aside. We don't really worry about budget, like really this is important, what we want to move forward. We take it and, okay, if there's less funding, just give us whatever is there. RFA can go in two different ways too. So in the past, we had a Barrett's esophagus specific RFA, and it was so popular that so many applications came in. I think we could fund 5, and there were 100 applications.
That would be a great problem to have.
Yeah, yeah. So, I mean, we did fund 5 applications, but that was all the money was available. But then people got like very good score and didn't get funding. But I think that's a way, yeah, you're right, that is the way to stimulate the field,
Yeah,
so they
I
can
mean,
come
'cause,
back.
You know, I was at the UW for 20 years, and there were you had Brian Reed, and you had the whole BetterNet thing, and I felt like there are so many parallels to Barrett's, and this is right for that type of translational research group, and that's
Right.
what we need.
Yeah. So one of the area that's at very high priority for NCI director has been talking about is early onset cancers, the increase in the younger age. So the gastric is in one of the. This is something going on. So in gastric space. So maybe there will be a funding opportunity that the NCI director is interested in bringing it forward. So it's
Are there
probably
things that
more.
we can do to increase the likelihood of getting an RFA specific for gastric cancer, to set up something like BetterNet that might include, I would hate to have just an RFA that just addresses early cancers, because I think, we have a bigger problem, and just to focus on that, if it should include that for sure.
Yeah.
But it would be nice to address the larger problem.
Right.
And get at both kind of molecular diagnosis mechanisms, but also, how to translate that into clinical care.
Yeah, so so what we are thinking about is something more like a precision cancer prevention centers.
Bingo.
Yeah, so that's the official title of funding opportunity, and the first one to target there is gastric and esophageal, because we had the CTAC subcommittee that was independent experts that gave us recommendations, like just what I mentioned, like the lack of resources and what we need to have research community need to have those, build those biospecimen resources, patients, so we can really do some translational research.
Yeah, and one of the reasons that we created this summit and invited the NIH specifically is to show that we do have that community, right? I mean, I think that everybody here, we work well together. We've seen the data that we have, but it comes from all over the world.
Right.
And so it's not like that there's a paucity of researchers, and it would be great if the NIH could help to unify us, and that we can do stuff that we can't do independently. I mean, I think that's what the NIH can really do for this field.
Right.
Sorry, just wanted to add, and then echo what Juha just mentioned, because we are actually quite behind. Unlike other cancers like cervical cancer, colorectal, breast, it's actually gastric cancer kills a lot more than, for example, cervical cancer. But the attention to the research and investment put into gastric cancer prevention is actually really relatively low. So what we are trying to do is through these opportunities, from NCI and then from Stanford, and then also IARC is trying to draw attentions by holding the IARC working group meeting, and then also we are also planning the reevaluation of H. pylori as a monograph program, and then also the hopefully upcoming handbook as well. So as a H. pylori eradication is the strategy for gastric cancer prevention. So these are the opportunities I think that we can take advantage of. But since we are now starting and moving relatively slow, but we are surely getting there, and I'm so pleased to be here. So what I'd like to emphasize is that while the etiological work and then all the important, like precision medicine is important, but we also need to make sure that those prevention strategies and the treatment like are accessible to everyone. And then also every life matters. And then IARC's, the global data actually really shows that we expect to have new wave of gastric cancer cases solely due to demographic changes. And then that is important, and we already know that. So we really need to take an action, and then just ignoring is not an option. So we, as scientists, as clinicians, as researchers like who are working on gastric cancer prevention and then treatment, we actually really need to make an effort and put resources and then efforts into that one. So yeah, I'm so glad we are discussing all this together.
Thank you. I wanted to bring up a comment, which is it's really wonderful that we're starting to see some small pilot trials for endoscopic screening. I think Hagen had introduced her trial, and we heard about the Kaiser pilot trial yesterday from Dan. But, I've got to say that the difference in the sizes of these pilots, I think it was, 50 or 100 patients, versus, hearing from Paul yesterday, the size of a trial that you would need to adequately power a cancer endpoint. For H. pylori, he was saying 50,000. If you look at the colonoscopy trial published in New England Journal a few years ago, I think that was 80,000. I mean, that's a huge difference to go from 50 patients or 100 patients to 80,000 patients. How are we going to kind of bridge that gap? Because even looks like these small trials, even a 100-person trial was already kind of hard to launch and required a couple of years. So to me it seems like there's going to be a big gap between that and a fully powered cancer prevention trial in the United States. I don't know if any of you have any thoughts on that.
Yeah, I can just add to that. Actually, not only that you need a larger trial, but actually probably need a long time to follow up for the disease to develop to really get the cancer endpoints there. That's definitely the case for pretty much all the prevention trials we have done. It's not impossible to get funding for that kind of an approach. I think you have to really probably put together a study like that that's reasonably powered, not initially starting as like we're going to follow up for 20 years, but I mean just like really start with the first.
Especially since the grants are all only 5 years.
5 years, right, right. You can extend it up to 7 with the no-cost extensions, but that's it. But then you can apply for. But I mean, what I was saying is like you need to have a meaningful endpoints that are done within 5 years, and then move from there and reapply again for competitive renewal for longer-term follow-up.
To follow the cohort.
Yeah. Which that's the model that we used for Andy Chan has just left for a spree trial, for example. There's 19,000 people for aspirin looking at events in elderly. It was actually originally submitted to National Institute of Aging, and a composite endpoint of death, disability, and dementia, 3 different endpoints. But when I found out, I said, well, we want to get the cancer endpoints in there too, because it would be silly to spend $100 million and not really get cancer endpoints in something. So we did that, but I mean, it is still ongoing. It's been its 15th, 16th year now. They got renewed funding, now passive follow-up. So, I mean, that's the model that could be used with a strong study design.
Yeah.
Yeah.
The thing about colonoscopy is we've been doing colonoscopy for colon cancer prevention, early detection for 20 years now without any clinical trial data. So I think as Doug was mentioning yesterday, if we don't, I guess the feedback you were getting from the committees was that well, there's not enough evidence, but if we don't do anything now, there's not going to be any evidence in 5 years either. So maybe I think it sounds like the documents that you're going to put out are going to acknowledge that there's a limited base of evidence, but that there's some evidence, at least, maybe not from the United States, to do something. And so maybe we just start with that, and then we start doing things, and then, then it doesn't need to be a clinical trial. Maybe we can turn that into observational data moving forward. What are your thoughts on that?
No, absolutely. And in a way, that's two birds with one stone. As we think about the guidelines and quality indicator documents that are in press, the next big challenge is implementation. And I think we'll have to work together in terms of networks as far as implementation and then studying the implementation phase. And that in itself becomes a network to think about some of these bigger trials. And I'd like to actually think about implementation. Yes, we can work at the national level, GI Quick, et cetera, and society GI with pathology. But integrated health systems are also going to be key. And so I wanted to
You're
ask.
so lucky that Andy walked up to the microphone.
Well, that was a plan.
I heard my cue.
And then I'd like to have Dan come up also, because Kaiser is key, the VA is key, and I think our academic networks are also key.
I mean, I think for, GI Quick, if we could do it like for Barrett's as we were talking about, I think that'd be something, because these procedures are being done, but how to capture. To take a step back, though, I think there are a couple things that come to mind. One, when we have these guidance documents, these guidelines, which are great, it's going to involve communication. Social media, impressions, the societies do some of that. Our trainees will pick this up, but we have to get it out there, not only to the people who are training, but the people who are in practice. I think that's very important. Because there's a lot of guidelines, and I think there's a lot of things being published, and there's only so much time for people. So what you can highlight and get front and center is very important. The second thing, though, is really the quality part that you were alluding to. I mean, we're already doing so many EGDs, and if they were just done in a higher quality fashion, the impact's already there. Because quite honestly, I think it doesn't matter even if we have great guidelines and data, unless these procedures are going to be pretty much paid for, like other screening tests. As insurance becomes more expensive for people, as the co-payments are higher, even if we recommend it and the patient can't get it at an affordable way, it's not useful. And so, I think that's where the data comes in. And but I do think it seems like a very far reach, like you were saying, Robert, to get from, if we get the DoD 600 patients to like 60,000 patients, right? And so I think we have to cobble all those things together. But yeah, I think for me, education right now with what we're going to have is going to be the next step, and then kind of move it along.
Great comments, Andy. So Kaiser will actually, I can use an example of ADR. I think it's very similar to this, which is going to happen. So several years ago, we didn't have ADR program. But we have that, the ADR guideline from guidelines to measure ADR. So then we set a program in our region. I'm actually in charge of ADR measurement in our region. I'm quality lead for Northern California Kaiser. So we actually started to measure ADR across among all gastroenterologists using the same standards. So then we measure ADR. We have to report every 6 months. So then we actually, the chiefs start to use ADR to talk to our gastroenterologists in terms of like incentive for their, like, say, their incentives or their payment, pay rights, for example, potentially. So that's actually definitely increase our quality across the board. And for this one, for upper endoscopy, I think we're doing a very poor job so far. So I know that in our institution, we actually do a with high variation in terms of quality. We don't really use MBI in most cases. And so I think the quality document is really the key. So we have that guideline coming out at GI Quick to show us this is actually the standard of care. Then we can do the same thing. We can actually, I think the first step would be education among all gastroenterologists. We have 160 gastroenterologists across the region. we can do the training session, and then we can let them know this is the standard of care. Then we can actually do some measurement after that, say in 6 months to a year, to see how many are taking biopsy from gastric body and antrum in 2 bottles. That's actually a very simple measurement we can do. And potentially GIM measurement, but that's like another level. That's something we can actually implement in our setting.
What do you think the ADR should be in the upper GI tract? Is it
Well, ADR,
findings?
the tricky part is depends on your denominator. Say if you if you do endoscopy among, say, non-Hispanic white, the metaplasia detection will be very low, probably. So it really depends on your denominator, which is very different from your just do colonoscopy across the board. They're overall kind of similar, but for IM is very, very, very different among different populations. So I think that's a barrier to implement that as a quality metric. Unless you have, say, you have 30% Asian in your center, and then you have the same thing in different centers, then you can measure that.
Yeah. Well, I think it should be bigger than just the stomach. It could be esophageal
Yeah,
IM,
yeah.
gastric IM.
Right.
And then you might get to 25%.
Yeah, I think that the quality shouldn't be just on intestinal metaplasia, right? I think, and we've kind of hit on that throughout this meeting, and I'm really glad that we're talking about this. But it should be it should be anatomic, right? It should be all findings in the upper GI tract. And again, we're so used to being siloed, and right, this meeting is a perfect example of that, right? I mean, we're just talking about gastric cancer, but you know, we're joking. We don't close our eyes as we go into. It's like, oh, we're in the esophagus, so we can't look. Okay, now we're in the stomach, and we're just past the cardia, so now we can open our eyes. You know, I think what we need is a good study that says, you know, and I think you reported on it, or someone did, on, you know, what the findings are, you know, how often you find an abnormal finding, and I think that could be your metric, you know, and for people who never find anything on endoscopy, there's a problem, you know.
The low-hanging fruit would be like focal documentation, how many photos take an endoscopy, and also do you take photos to cover all the corners and segments. That's probably the one thing we can do. And also the number of biopsy, the number of bottles you put in stomach or in esophagus, for example. So those something very simple to do, plus minus the metaplasia measurement.
I just wanted to go a little bit back to what Doug said, and then we had great discussions about endoscopy, but I think that implementation aspects also apply to the primary prevention. And so I think what Dan is doing in the Kaiser, I think is very valuable, in that sort of pilot studies, and then the Dr. Kuma and then Aplin community-based studies and so on, that these actually tell us what the barriers and facilitators are, and actually that just also make us understand, what sort of the infrastructures, for that specific settings would be needed. And in terms of that, for example, the not only the community-based, regional-based studies are important, but also something like a USPSTF, that sort of process. If somehow, if the USPSTF can approve that the component of the preventive strategies, and that would be really helpful. So it's so we need to somehow work from all various aspects, and then I think it's very important that we basically conduct and then go ahead and start, however small that is, to do something to collect information. And in terms of also age prioritization as a strategy for gastric cancer prevention, of course, there are always pros and cons, but we will never know, and then we will never be able to quantify or qualitatively evaluate for the specific population or region if we don't do it. So it is very important that we somehow try to move towards the implementation and then try to collect more information from the implementation aspects.
And I think continuing on the USPSTF line, because we're trying to think about what we can do short term to kind of move the needle. And I think Yang He talked about it, and I've talked with others who provided feedback. So the primary prevention with H. pylori test and treat is not dead with HPF. It just kind of received a lower priority. And essentially what we need to do is kind of hound the USPSTF. We have documents that we can provide you. Each individual can easily submit a recommendation for review. And so the more of us who and it's a really simple process. You just go online and you write your name, your institution, what you recommend. The more people who do that, I think the higher the priority it might take with the USPSTF. But again, Paul, who's not here, but he's probably one of the most critical people I know in terms of methodology. If he says something works, I believe it works, right? And so he's as rigorous as they get. And so I'm confident that this will pass the USPSTF at some point. But I think that it's upon us to remain persistent and just continue to submit to the USPS to remind them that this is an important thing for them to review. So I encourage you all to do it in the next few days. You just Google USPSTF guidelines, and there's a submission process. If you need any supporting documents or need a blurb to put in there, just email Rob, and he'll give you what we submitted. So
I'll be provocative, and I won't be able to answer the question, but should it be CAG-A instead of H. pylori?
I think CAG-A covers some of it, but like Miera talked about, it doesn't cover everything. So I would start with H. pylori, and then I think that this is an area of interest, and because we know that that's the main virulence factor, and so I think there's not enough data specific to that to warrant that, and I think there's plenty of studies out there for H. pylori in general. But again, this is the closest thing we know to the truth, and we need to refine it, and that's where we're going to submit grants to the NIH for this. And so I think that's actually a ripe topic for investigation.
Yeah, I really agree with Juha as well, and I understand this important role of CAG-A, but still at the population level, we also shouldn't undermine that there's also other positive effect of H. pylori eradication for other the clinical outcomes. So I think that, of course, cost effectiveness and everything needs to be evaluated for the specific settings, but still, when considering all other potential benefits as well. So probably targeting H. pylori wouldn't be a bad option.
One question, I'll put two colleagues on the spot, Dr. Lee and Dr. Camargo. I think we see, in terms of risk within the U.S. in our heterogeneous racial and ethnic groups, we have disaggregated data for Asians, but we do not for Hispanic Latino populations. And yet the risk is widely, we hypothesize that the incidence rates are similar to what we're seeing in Asia based on the international reality. So how can we, Dr. Lee and Camargo, is there a way that we can disaggregate this data?
So I think to disaggregate the data, we need a population estimates by country of birth. So it is even more difficult to dissect the population estimate by country of birth for Latino population. So we have tried in California, and there are so many unknown, even among the cancer patients, let alone in the population estimate. So that was a real difficult job. So we tried, but it was not doable.
I completely agree. Yeah, it's difficult, and something to consider is the Hispanic Latino groups are very heterogeneous, right? And we have, for example, more Cubans in Florida, right? More people from Puerto Rico in New York. And we know that based on the data from Latin America, we start with a rate of 3 per 100,000 in Puerto Rico to almost 17 per 100,000 in Chile. So the risk of gastric cancer in Hispanic Latinos in the US is like an average, right? So we have something that is about 9 overall, right? And we see interesting observations, as Dr. Eplein showed to us, for African Americans, that there is not a cohort effect in the acquisition of H. pylori, right? In people from Central America, based on our study of Latinos, we see that there is no cohort effect, so there is an active infection. So clearly there are some populations that are more susceptible, right? In my opinion, not with the best data. I think that Guatemala, particularly the Central American region, Dr. Morgan has showed that to us, the rates are very high there. And also Haiti. I need to confess that I didn't believe the data based on mortality, but based on the work from Dr. Kumar, and she showed us the prevalence in different Hispanic populations, it seems that indeed Haitians have one of the highest rates in Latin America. So yeah, we need to work on that, but it's really difficult. The segregation is difficult, but we need to continue pushing to get it, I guess, yeah.
And then data collection step itself has to be revolutionized, because for now, for Asians, we have the ethnicity checkbox for the census population estimate. I can answer as a Korean, and others can answer Chinese. But for Latinos, they don't have ways to check different ethnicity other than marking off for the country of birth if they were first-generation immigrants. That's one thing. And that's another issue for the cancer reporting. So we don't know if someone is their origin is Mexico or Colombia or Haitian, the more high-risk areas. All we know in California is the vast majority of Latinos in California are from Mexico. So that's a real kind of argument, and our estimate from California are largely reflective of the risk in Mexican Americans among the Latinos.
May I comment on some of the Latino data that I originally asked Juhan about the missing mortality situation? It also happens in Hispanic groups. When we were running the analysis for Asians, I did a run on the Hispanic group for lung cancer. It turned out the states that are closer to Mexico tends to have much lower deaths than the East Coast cities, where they're from other parts of Latin America. So this data is we have a serious data problem.
Thank you very much for pointing out the important problem issue. Like it's one of the previous speakers also showed the global map, and then you see the lack of data in many parts of the world. And IARC's Global Can data is only an estimate from these population-based registries. So I think it's not only in the U.S., but it's U.S. is also a really high-income country. But then we cannot imagine other countries with the lower resource setting. So it's really important. One of the Dr. Morgan's really important work is really to try to establish the population-based cancer registries in different countries. So I think that sort of efforts, global concerted efforts, are needed. If we don't understand the outcomes, it's very difficult then to plan the preventive actions. And so it's important to understand the disease burden itself. And for that, I know that some collaborations are active, and that sort of support is actually really globally appreciated.
Anybody have any other questions or comments before we start to wrap this up? No one. Okay, I think we're ready for some wine and cheese. Allison. Is Allison here? Where's our staff? I want to bring our staff in because I want them to Yeah, Lee, Hunley, can you tell them to come in? I want them to personally be acknowledged. But I guess before that, to close the meeting, one, I want to thank everyone for coming in and spending the last couple days here in Palo Alto and Stanford, and for all your valuable contributions to the field. Since we started this 5 years ago, we've clearly made amazing progress, much more than I could have dreamt of. And so I want to thank everybody for contributing to this and for the call to action. Some priorities that I take from this particular meeting is, one, I appreciate the efforts from the societies to have the best practice advices and the updates of the guideline. So now I think with those, we need to get those implemented. So I think the real call to action is, to start implementation in quality and endoscopy, to see how that changes in terms of detection of lesions. This is an educational effort on our parts, and I think it's upon us to get the word out that these new recommendations and guidelines are out there. I think we're glad to see pilot studies underway, because we didn't have those before, and so we're finally starting to do and not just talk about them. We still have opportunities with the USPSTF, and so hopefully by the next time we convene, we actually do have recommendations from the USPSTF. I think we're close. And what I'd really like to see is an increase in NIH-funded grants related to gastric cancer. As Asad mentioned, that's up to us to put in good grants, but I'd also like to start some dialogue and interact with the NIH to get a specific RFA, ideally something like BetterNet, to unify this group. I think we have the infrastructures here, so I can tell you that if we have this, we can start a day early, for the research conference, and segue this into the Gastric Cancer Summit. So happy to make this a 3-day meeting. So with that, I want to personally thank and acknowledge, actually come to the front. You guys get to come to the front. So we have Lee. Come on. This meeting would not have been, Karina, come on up too. This meeting would not have been possible without the efforts of Lee, and she has a newborn, so it's particularly hard on her. So I really appreciate all the sacrifices and her effort, and she'll continue to hound you for receipts and stuff like that. So if there are any loose ends, please address them to Lee. Allison, who is relatively new to the team, who helped a lot with the logistics of this. Karina, who is actually one of our directors of care in terms of the administrative side, and she managed Nina, Jenny, and Erica, who were also here to help, but they were allowed to leave a little early. They're cleaning up, so if you see them, thank you. Sally Lee, who's the executive director of care, and of course, Donka Wu and the Fortinet Founders Foundation for supporting this. I will do my best to raise funds for 2 years from now so that we can have another Gastric Cancer Summit. As hard as it is put it on, just to see you guys and to be together in this environment and to advance the cause for gastric cancer really makes this all worthwhile. So thank you very much. Safe travels to everybody, and let's enjoy some wine and cheese.